You're watching How Can GP Supervisors Better Facilitate Reflective Practice in Their Registrars? Produced by GP Supervision Australia and presented by Associate Professor Cern Prince. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
It is a wonderful pleasure to introduce a colleague and a friend now, an international speaker in Associate Professor Cern Prince, who I'll allow to introduce himself a little bit more fully in a second. But he is talking today about a topic, I think, which we often pay lip service to in some respects in our role as supervisors and educators in GP training in terms of facilitation of reflection. But one I think that really we could spend a lot more time practicing the skills of and really focusing on when we support registrar development. And it was with great excitement that I heard of Cern's work and thought it would make a fabulous educational session for the supervisors here in Australia. So thank you so much for coming. The learning objectives, and really I've sort of alluded to those, we're talking about reflective practice and how we can make the most of that and encourage our registrars to really incorporate that into their learning, not just for their time in GP training, but as lifelong learners over the course of their careers. So it is a great pleasure to formally welcome Cern all the way from Denmark to lead this on reflective practice.
Thank you very much, Simon. And thank you for the opportunity to talk a little about reflection and how we do postgraduate GP training here in Denmark. And first, a little bit about myself. I put on a slide here with a picture of my waiting room, and I will just give you a short tour of my consultation room here in Silkeborg, which is a town in western part of Denmark, in Jutland, with about 100,000 inhabitants in the county. So sort of a medium-sized Danish city. I've been general practitioner here in this practice since 2008. We are 4 doctors and normally 1 or 2 registrars, and we have some staff, 2 nurses, who do a lot of our checkups of chronic disease like type 2 diabetes or asthma and that sort of stuff. A couple of secretaries, and then we have some medical students who work here as student job. They will cover a room, so they are here like 1 day a week each, and they take blood samples and help with different stuff. And then they get introduced to general practice so that maybe they will want to pursue a career in general practice. That has become common in Denmark just over the past 5 or 6 years to try to engage the medical students by giving them student jobs and thereby maybe inspiring them to general practice. We have 5,600 patients for my practice, which is a little less than the norm because I have a job also as educational organizer and associate professor of Aarhus University, which I spend about 25% of my time on. Just for the introduction here, before we go to talking about reflection in medical training, I'll just show you what GP training in Denmark is like. I talked to Simon about that, and he said might interest you, and it is a bit different, as I understand, from Australian GP training. We have a 6-year university study, and when they are finished, all new candidates are guaranteed the first year of work in a lottery system where they get a job somewhere in the country where they work 6 months in a hospital, normally in a department with a fairly large intake of acute patients. It could be an internal medical department or we have so-called acute department in hospitals. And then after that, they all work 6 months in general practice, meaning that all doctors in Denmark have served 6 months in general practice as when they were young. This is to help them becoming a basic doctor to learn how to apply the theoretical knowledge to the clinical work and help them find their way in their career and discuss choice of specialty.
At this point, I think I fell off my chair when we were talking a year ago, and I'm sure many of the audience are really looking at that and saying, oh my goodness, that's extraordinary. And Søren and I spoke about this sort of introductory discussion around general practice training in Denmark, and I said, I'm sure you could spend an hour on this and people would find it fascinating, and we don't have that long because we want to talk about the main game. So, but I thought it was interesting. But it's so difficult for us to facilitate learning positions for junior doctors in general practice to help support interest. And to think that every doctor has 6 months in general practice is so far from our system. What proportion of medical students pursue a career in general practice in Denmark?
About 25%, I think.
Okay. And I make the joke that there are now more smokers than there are interest in general practice in medical students. I think there's about 12% of the population smoke and about 11% want to do general practice or something of that ilk. So you've got double what we have. Anyway, I'll let you carry on.
Of course, I don't know how many actually want to pursue a career in general practice as their first choice, but that's how it ends up. And actually having 6 months of general practice in internship is not a unique thing in Europe. I think lots of other European countries have the same. Britain have this 2-year foundation program where general practice is also involved. And I know the other Scandinavian countries, and I think also Holland or the Netherlands, they have similar internship programs. But what is unique to Denmark is that before you choose your specialty, you then apply for and can get an introductory post, which is 12 months in all other specialties and 6 months in general practice because they already had 6 months in their internship, where you can, taste the smell of the room, see if this is something for you. And also where your trainers within the specialty can test, is this someone who is trainable in our specialty? Would we advise this person to continue in our specialty? And then you have to apply again for the main specialist training, which is the most difficult part of it. And sometimes they will have to wait some time to get the one they want. And in that time, they can take maybe another introductory post in something else, or they can always get work somewhere. But then when they have got their position for main specialist training, they have still another 4.5 years to go. That is divided between 2 years in general practice and 2.5 years in hospital placements in 5 different departments. And the outline you can see on the slide, 6 months in the same clinic before and after the hospital placements. And during the time of hospital, they'll be back working in the general practice once a month, just 1 day, coming in, saying hello, keeping in touch with the specialty that they are training for, and they'll become a part of the clinic. We'll invite them for whenever we have some social arrangements and that sort of stuff. And then they go somewhere else to another GP clinic for the last 12 months. So that is the outline of our specialist training, and they will have some theoretical courses, about, I think, 30 days of theoretical courses specific for general practice, and then there are some that are common for all specialties. I'll just mention a little bit about assessment in our education, because that is something that resembles things that are done abroad and yet also not. Our assessment is based on workplace-based assessment. On the right side of the slide, I have put Miller's pyramid. I don't know if you are familiar with this. It is a famous article from 1990 suggesting different levels of knowledge in workplace-based learning, in which you learn something that you go to know how, to show how, and then to simply do something. And if we want to test what people actually do when they're at work for real, we have to test it in the workplace. And that is why we and you in Australia use workplace-based assessments, in which the tutor that they work with come and watch them have a consultation or have a case-based discussion about real cases they have seen in their work. In Denmark, this workplace-based assessment works both as a formative and a summative assessment. And there's common agreement in Denmark that a specialist exam in which you go away from where you work and maybe take a kind of a knowledge test or simulated something, it does not reflect what people are actually competent to do in their daily work. And the fear is that it will take focus away from training to be a good doctor into training to pass this exam, and that we won't find the bad apples in a knowledge test or a simulated test anyway, because what the experience is that doctors who struggle and who render in problems later on, often these problems, they are not attached to knowledge or something that you could do in a test away from your work. So we don't have a specialist exam. If Simon fell down from the chair when I said everyone's going to general practice, then my experience is that often when I meet people from abroad, they certainly think that this is completely insane, and they're worried about the quality of our education when they hear that we don't take them away for a specialist exam. And that is the same for all specialties in Denmark. We trust in the entrustment decisions of the counselors, the tutors where people work, and it's up to them to raise a flag if someone is not working well enough and to help them evolve and develop at whatever level they are. So that was a little bit about the setting I'm in. My function is to supervise the supervisors, the tutors, kind of what I think you do, Simon. And I do courses for them and visit the clinics whenever there are problems. And I also have contact with the hospital departments where they work along the way, and other kind of administrative work with the education. And then nationally, I participate in curriculum development and that sort of stuff. So I will move on to today's topic, which is how I see the enhancement of reflection as an important tool in our work as clinical supervisors or tutors, whatever you call it. First, I will present something generally about enhancing reflection and how I see it. And then I will introduce an assessment tool that we have developed here in Denmark for assessing the ability of reflection for GP trainees. You are all clinical tutors and you do clinical supervision every day. There is lots of evidence that this clinical supervision will increase the learning outcome of the work you do. It also is important for psychological work environment, that, the feeling that you have a tutor who has your back when you are out there working with the patients and who will sometimes give you an encouragement or tell you did a good job and help you with your struggles, whatever they are. And that a good psychological work environment is, of course, critical for being able to develop and become a better doctor in the end. So there's good reason for us to do this and to spend time on it. And just to get started, I've taken this picture of the divers, and that is probably a more common picture from Australia than from Denmark. We don't have waters like this, unfortunately, but it's meant to illustrate how supervision of the registrars, ideally and sometimes on a good day, could be to an activity of exploring and looking at cases and the material we have from different angles, and dive into the details and maybe look at things from another angle that will help the learner to have more ways of acting, give them more opportunities in their daily work. And if we can help the learner also to see not just the different angles, but also sometimes the task may be to guide them the right way through this reef, so they can find the easiest way back out through the things they need to see, then we have done a better job than if we just instruct them on what to do. And I've written here a statement that the aim of all our supervision and feedback should be to make the learners reflect on their own practice. That is, that when we're done with the feedback or supervision, then the learner should have learned something new about how do I, Søren, work as a doctor and have some more opportunities and be more sure to work with the patients afterwards. To be fair, there are situations where it's most appropriate to instruct. To give a short answer, maybe the trainee is doing something that might be harmful for the patient, or they're just asking, I want to refer a patient for angina, which clinic should I use? Something like that. Often the kind of questions that the trainee could have Googled or checked in some kind of guideline where there is just one answer. It could also be the dosage of medicine or something like that. But most often could do is, and what we often fail to do is to guide the learner to find the solutions themselves, which could provide them and improve their sense of self-efficacy and train the ability to find the solutions more independently the next time. There are also different kinds of working as a doctor. Especially the youngest doctors will often ask for a guideline, an algorithm to go by, which makes the doctor feel kind of on safe ground. I know that step one, step two, I know the way through. You go left, you go right, and then you give 800 milligrams, and then you wait 5 days, and then you follow up and you take these blood samples, and then I've done what I'm supposed to do, and nobody can criticize it. But what we also want them to do is to be able to know how did the guidelines, how were they made? When should you not use the guidelines? How do you use them for this particular patient who may not want to take so much medicine, says, I will only take 4 different kinds of pills. Help me choose them. If we don't help the trainees reflect on their practice, we might get doctors who won't be able to take the next step away from just guidelines and safe question answering. Some theoretical work have divided supervisions into clarifying supervisions, which is direct instruction or confirmation of a decision, and what they call expanding or broadening supervision that seeks to generate reflection through questions that create a productive struggle that links knowledge with practice or broadens the case. The term productive struggle is like covers the thing that you can have a struggle where you don't know exactly what to do, but still are within your capability of finding out the solutions so that it has an ending with finding a solution for the patient, the kind of struggle that will develop your skills. You could also imagine giving a trainee the kind of struggle that will be too much, that will make them feel incompetent or unsafe. And that is, of course, not the kind of thing I'm talking about, but it's something we have to think about when we use asking questions, probing reflection, that we don't set the trainees out on thin ice or make them feel left behind by their trainers. Asking good questions is the key to enhancing reflection. We go from speaking knower to good listener and probing questioner. Speaking knower is also the kind of doctor who likes to tell about all the good stories about the patients he's met before. Often these great anecdotes are not what brings the learner on to the next thing, but instead good questions would help them find the way themselves. I know you guys are all experienced trainers and you all have experience with young doctors as far as I know. So I assume that a lot of this will immediately make sense and look like things you've heard before. So there's nothing wrong if you think, oh, this is what we have heard earlier. But I will just repeat some of the things that we can do to enhance reflection and ask good questions for our trainees. There is something that you could call investigative questions. What are your considerations? Ask them, why did you choose, for instance, to give an AT2A, or why did you choose these tests? Why do you think she seeks the doctor right now? This picture you're seeing, is that normal for people at that age? Or it could be the thing you're suspecting. Is that normal for people at that age? Young person coughing, and maybe the trainee suggests, well, could it be cancer? And you say, oh, is that normal for people at that age? Or what are his risk factors? And then just see, did you ask about specific symptoms, concerns, something that could bring the doctor on? Then there is a type of question that is more challenging or broadening questions that will, if you have a case where you think, okay, this is going pretty well, but if we want the doctor to reflect and develop and become better, we could take the case somewhere else and see what could have made you choose to refer the patients. That could be, okay, it was right this time to treat the patient here in our clinic, but what could have made you choose to refer the patients to help them see the difference between a patient that might be more ill? How does this situation differ from what we saw last week? Or what if the patient had a fever? Would that change your decision? Would it affect your decision if you knew that this patient had an MI 2 years ago? What do you think will happen when you see this patient in 2 weeks? What are your plans? What can you do if your treatment hasn't worked? That sort of stuff. What if this patient had been 20 years older? Would that have made any difference for you?
And so it's interesting, Søren, the questions there, the challenging or broadening questions. One of the participants has just put in, this is random case analysis, and indeed the model of random case analysis that we use here is very much that investigative.
Yes.
Tell me more about why you did what you did, and then the so-called what if questions, and sort of broadening and challenging where appropriate. So interesting. And I think I remember having this conversation with you and your team about reflection, and thinking that perhaps in Australia, as educators and supervisors, our definition of reflection maybe differs a little bit from yours, and maybe in doing some of this stuff, we're maybe not actually fully aware that that's exactly what we are doing, encouraging reflection. We probably don't put it in quite into those terms, whereas it's a bit more explicit in your landscape.
Yeah, and maybe we call it different things. There's nothing fancy or new about this. And surely that is incorporated in several of the tools that you have shown me, and we use similar ones here. My only point about this is that I think we should try to use this type of supervision in all kinds of encounters, also on the daily level when we don't have so much time, but still, if you only have 5 minutes to talk about a case, you can still try to induce reflection. A couple of pitfalls, I'm sure you're aware of them. Try to avoid what I call the examinator trap. There's a whole thing about the more you ask and the more you challenge your trainee, the greater the risk that they are going to feel embarrassed or ashamed of something that you could not know that would hurt them. So you will have to ask them about afterwards, how does this feel? I just put this in because that's another of the models that might be familiar to some of you that tries to implement some of the same things. The keys to success for supervision and assessment is to have time, of course, but also, in my experience, the registrar's preparation. They often come with the material, the good case, so that they simply have prepared a case that you should talk about. They think, what do I need help with in this particular supervision exercise today? And then I will just mention the 40-20-40 model, a model for company training developed by Robert Brinkerhoff from, I think, University of Michigan. He postulates that 40% of the learning outcome of a training course or a training activity derives from the preparation. Why do I need this course? What will it help me, etc. 20% comes from the course itself, and 40% from the implementation and the follow-up after you come home from whatever learning activity you go into. And I think you could just keep this in mind when you have assessments and training activities with your young doctors, that their preparation, what they bring to you, and what they do with what you talk about afterwards is crucial to the outcome. So I will go on to assessing reflection, because that is the thing that I can bring you that is kind of new. When we were to revise our curriculum 10 years ago here in Denmark, we had two things we wanted to address. One thing is that some competences require discussions that are broader than a series of patient cases. That's something that you cannot assess just by watching a single patient encounter or taking a few reports from the journals and discussing patient cases. That could be things like competencies like ethical issues or something about the doctor's role in the system and so on. But also more complex competencies where many factors are involved in the patient treatment. And we found that it's important that also specialists can reflect on complex competencies and are able to see the bigger picture. That could be a patient with back pain, in which, their social situation, their work, their family life, their concerns about what will this end with, but also things that are in the community. How do they get paid if they have a back pain and cannot work? All these kind of things. We needed an assessment method that would help the doctors reflect on complex competencies like that, and to also assess simply their ability to reflect on such things. So we developed a new tool. Part one is an important one. It's a concept formatting process in which the registrar prepares a mind map or something else. It should be a written presentation of some kind. Could be something else than a mind map, like a whatever, a drawing, a few notes, something where they will reflect on a competency, give them a couple of weeks to prepare, let them be inspired by the description of the competency, and then you have a structured discussion between the tutor and the registrar based on the mind map when you meet again. We did a validation study showing that it was found useful and relevant by trainers and trainees who have tried it. And then we did another study on construct validity. That is, we recorded some of these structured conversations to see if reflection is actually taking place, which it did. I will not go so much into the validation, but there is an article from the Journal of Education of General Practice, I think it is, in Britain. I'll just give you an example. This is our competence number 79, which is called Personal Development and CME. We want new specialists to be able to plan their own CME and be active in their own professional development, as you know that every doctor should do. In the right side of the picture, you see the description of the competency, planning CME activities, which includes audit, self-reflection, working with adverse events, and so on and so forth. I did a mind map in one of these web-based mind map services about my own thinking of my personal development and education. So this could be the preparation that if I was to have a discussion with my tutor, I would prepare a mind map like this. And then when I show up for the structured discussion, then I present this for my tutor. And Simon and I have agreed that we're going to make a small demonstration in which Simon will be my tutor, and he will ask me some of his good questions to try to see, is this person able to reflect about it? Could we have a discussion about what are his thoughts about the CME? Is it something that he simply put down because he read somewhere that you should do this kind of stuff? Or is there a resonance when you ask questions about it?
Yes, so thanks, Søren. This is a really nice overview of the competence, and I see you've put a bit of thought into it. Overall, I'd be curious to know, how do you identify your strengths and weaknesses in these particular areas?
Oh, yeah, that's a good question, Simon. I think I have a general knowledge about my strengths and weaknesses, but often of course, they're kind of hard to see all of them myself.
Yeah.
But I've learned that some of my one weakness that I have is to be structured in planning this kind of activity. And I actually, we have a portfolio system here in which you can register all your CME activities, but it's not compulsory. And I sometimes put things in there and sometimes I don't.
Yep.
But now that you're asking, maybe I could, maybe I could get more out of it if I was, looking at it and seeing what kind of CME do I need.
Yeah.
Yeah.
And you mentioned reflection with colleagues
Mm-hmm.
during various activities. Can you actually unpack that for me? Tell me how do you actually do that
Well,
reflection?
in my where I work, we have actually we have an extra room that, well, you could say it's our lunch room, but we also have workstations there so that we can sit there when we don't have patients. We go out into this common room where we also eat lunch and stuff and do our paperwork or administrative work, we should
Yep.
say these days, which gives an opportunity to talk with my colleagues about, sparing about cases and stuff, things
Yep.
that I might not, go from my chair, knock on their door, and ask about. But now they sit next to me, we can talk a little bit.
Yep.
And we also, we have lunch breaks and coffee breaks where we assure that everyone will come there so that you can, and it's allowed to speak about patients there. So that's just the daily
Yep.
reflection.
I'm
Yes,
curious,
I think,
which of
yeah.
these areas of professional development and education do you think actually gives you the best opportunity to self-reflect? When you think about those different things you do, which one do
Oh,
you really think?
I think I couldn't be without any of them. But of course, the daily sparring with my colleagues, but also my CME groups. I have a group of 9 other GPs that I meet with regularly and do CME stuff. And it's a very comfortable or safe group to be in and ask questions. So
Okay.
if I should pick a couple, that would be it. So this is the kind of conversation. Let's stop here. Thank you.
I can
Nice.
tell you you've satisfactorily passed competence 87. I shall tick you off and
Thank you.
you will not need to sit an exam.
Good. And of course, this could end up with saying, okay, there are some minor things that you need to work on. Let's do this again in a couple of weeks, or let's follow up. So this assessment could also end with that. There was another example here. We have a competency about the GP as a care coordinator, and I just made a handwritten mind map here. You can also see that on this one, there are some examples with this is a birthday KS to remind me that I had a patient there that we could talk about. And the key to success here is the protected time for supervision and assessments. I don't know how it is in Australia, but here in Denmark, it's common that you have half an hour after lunch for supervision with your tutor when you are a registrar in general practice, where we can either talk about today's patients or talk about an assessment like this or a case-based discussion about a certain topic where they have picked up 2 or 3 cases on heart disease or whatever the topic of today is. And for this to work, we need the registrar to prepare and to make a good mind map and to put a little work into this. But what I hope that you could see is that if they have done this work and taken some time to just write some notes, it makes the job so much easier for the tutor to be able to. Simon, he just had to say, okay, you say strengths and weaknesses. Can you tell me something about that? You can pinpoint anything here, and you can just ask the type of questions that you have in your question archive as a trainer. And it makes it a lot easier for the tutor to have a good reflective discussion about these complex topics that might otherwise be difficult, at least for me, to talk about if there wasn't a preparation to talk about, for instance, CME. Oh, do you do CME? Yeah, I do. Yeah. Are you good at planning it? Oh, yes, I am. That could be very short and not very good discussion that will bring the trainee any further in their development. So that is the idea of this and the key and also the hard part because, well, the trainees, they might not understand what is the purpose of this and why should they prepare and that sort of stuff. But I think we get most of our trainees now to do things like this. I hope you got an impression of what this tool is. If any of you want to try it out or dig deeper into this reflection tool, you are also welcome to write me an email if you have any questions.
For me, the really key messages here are preparation by the registrar. And I remember when we were talking about preparation for this, you talked about the 40-20-40 rule, which I thought it was something I hadn't heard before and how powerful that could be. But also, this preparation doesn't need to be some really complex, detailed thing. But if the registrar just thinks a bit about the cases they present or the issues they're challenged by in advance, it can be so much more rewarding and facilitative of that conversation. So for me, they're the key things around preparation and then using some sort of tool like the mind map or equivalent. Thank you very, very much, Søren, for your very, this quite a different take on things, working in a different setting, coming from a different background, but in many respects doing very similar to work to what we do. So lovely to hear your wisdom.
Thank you very much for inviting me. It has been challenging and fun to work with you.
Jared, if you'd like to put your question forward.
Yeah, thank you for the opportunity. And Søren, thank you for the wonderful presentation. It's a great pleasure to have an international guest talking to us and seeing how you slice things up similarly but differently. Obviously, with your workplace-based assessment, when you're completely reliant on that for licensing, effectively, to say this person is competent, you've got to be confident that your assessors, that your GP supervisors or GP tutors are competent assessors. So just for international comparison, what level of training does a GP supervisor have to undertake before being accredited as a GP supervisor? And what sort of ongoing commitment do they have? And how are they specifically trained for the assessor role? 3 questions there.
Yeah. Thank you for that question. And that is, of course, very important. If you rely completely on the judgment of people who work with the registrars, then you need to be able to trust them, right? What we do is that we have, throughout the specialist training, there are some centralized courses for all doctors, regardless of specialty, trained in supervision and assessment. And normally, at least if you work in a hospital, as when you go on through training, you can start assessing people, the level below what you are. So they will have some training in being assessors already when they become specialists. We take them in for a 2-day course to be certified as a tutor, and then they actually are allowed to go on. We also demand that they participate in educational activities for tutors at least every 5 years. So that will go on a 1-day repetition course. But mostly we train them by supervising their work along the way, because we have coordinators throughout the country that when they see a trainee where they think, oh, is this good enough? Is this person struggling too much? They will write an email or grab the phone and call the coordinator where they are, and they will discuss things. And in that way, we will provide them with some help and support into making those decisions. And this may sound not very rigorous as a system, and it's not. Could it happen that maybe a GP somewhere thought that it was the easiest solution was to just pass this trainee because it would give less trouble, and if you don't pass them, there will be people asking questions to you. Why didn't you? What are your documentation? All that sort of stuff. Could it happen that they just passed them and let them move on without raising a flag that they should have? Yes, that could happen. And we hope that with all the many placements they have in our education, that things might be seen in the next place or the next one, or that in the end will sum up and people will know how to either help this one person or stop them if needed.
So I understand from that there's a lot of, in addition to the standard training, you're relying on the fact that they do go through multiple placements, which is important, and also that you're really doing apprenticeship training of your tutors as well. So there's a lot of your input into the practice. You the training program as it actually knows the practices and knows the supervisors and visits the practices and communicates regularly with the practices.
Yes, exactly. And we rely on that, but it's of course not a safe system. Yes.
I think we're not saying that answering a multiple choice questionnaire is a safe system either. So thank you.
No, probably not.
Thank you again so much. And I'll be in touch.
Thank you. Thank you very much.
All the very best. Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.